Welcome everyone, and thanks for joining in into this video podcast. I'm Karthik Murugiah. I'm one of the interventional cardiologists at Yale University, and I'm also an executive associate editor at JACC. And it's my distinct pleasure to welcome Dr. Fabrizio D'Ascenzo from the University Hospital in Turin, who's going to tell us all about this randomized clinical trial that they have just conducted and will be releasing the results as a late breaker at ESC, which looks at CT surveillance after left main imaging. So that's a really interesting topic. So tell me a little bit about this study, Dr. D'Ascenzo, and tell me, what was the clinical reason behind the study, and what was your hypothesis when you were starting out?
Yeah, thanks for the opportunity of being here. I work in the Division of Cardiology of the University of Turin, led by Professor De Ferrari, and this study was supported by the Ministry of Health of Italy, and we started by the observation that in-stent stenosis exerts a detrimental impact of prognosis, and this was demonstrated by many studies, especially from the group of Professor Castrati. Unluckily, randomized trial trying to evaluate the effect of routine angiography control in patients performing PCI, where most of them were negative. For example, the JACC trial, which show a neutral result. Anyway, we should remember that about only 5–6% of patients in the JACC trial had a disease of the unprotected left main. More recently, also the post-PCI tried to compare functional testing versus clinical follow-up of patients performing PCI, and in the sub-analysis of patients with unprotected left main and multivesicular disease, which was published on JACC last year, again, there was a neutral result. That is, there is no clinical benefit of a strict control of these patients. And also in this case, it should be noted that about 1/4 of the patients performed ergometric stress test, which also in patients with previous PCI is shared very low accuracy. So we wanted to understand if the new technology, that is the CT scan, which is not an invasive one, may increase the detection of stent stenosis, and if this may translate into a clinical benefit or not.
That's great. Yeah, this is definitely a really tough population, and the risk of restenosis and other events is really high. So it's great that that your team has looked at this question in the left main population, where selectively there could be benefit of surveillance. So that's amazing. Can you, as much as we are, curious about routine surveillance and benefit in such a high-risk subset like left main, we are equally intrigued by the use of CT for surveillance. Can you explain a little bit about why you chose CT modality, and what is the evidence for its success in evaluating stents, and especially bifurcations? Were you confident that this would give you that information?
Yeah, this is a very good question, and basically it was also asked to us by one of the reviewers of the grant some years ago. So now there is a good accuracy of CT scans also to detect stent stenosis, and moreover, our choice to focus on unprotected left mains leads to stents with a great diameter. And in these cases, CT scans offer a good accuracy. Moreover, I think one of the next steps of research may also be a perfusional CT. This was not explored in our trial, but I think that perfusional CT may overcome the still limited limitation of CT for stent stenosis.
That's a great point. All right, so we can just jump right into it. Give us an overview of the study design. How did you estimate the sample size? What was the study population, trial procedures, and follow-up?
Yeah, briefly, it was a randomized controlled trial, and only about 600 of patients performing PCI on unprotected left main in 10 centers across Europe and South America. And we recruited in a larger time, because our recruitment time started with pandemic. So it was a bit a slow enrollment as other many trials for these reasons. Interesting, I think that this was really a high-risk population. That is, 1/4 of the patients reported diabetes mellitus, and 70% of them were admitted for an STEMI. And I think that these clinical features also may explain the subsequent reduction in risk of MI, which was shown by our trial, because patients with diabetes mellitus and presenting with a STEMI had a very diffuse atherosclerotic disease, and so they are very risk of recurrent MI, both in the previous stented vessel and both in other native vessels. From an interventional point of view, this was a trial performed in high volume centers in a contemporary era. So I was a bit surprised by the high rates of imaging, which was quite high. It was about 17%. It was very similar to that of post PCI, which was about 75. So more or less, we achieved the same results. In few cases, we performed FFR. It was less than 5%, and very similar, consistently with our clinical practice. In most of the cases, we perform provisional stenting in about 80% of the patients, while two-stent strategy was chosen in 20% of them. For culotte was the most frequent one, followed by double kissing, double crush. And as usually, we implanted thin or ultra-thin stents. Thin stents were the most frequently implanted ones. So this is the depiction of our population.
Great. And you told me about the prior literature being great for use of CT for evaluating the left main. Specifically in this trial, what was the experience? Was the accuracy of CT good, and were the readers comfortable making these judgments? And did you notice any specific patients or stent configurations that were challenging, especially because you mentioned that a lot of it was provisional and less of it were like crush techniques, which are often used in, at least in the US, it's in a distal left main, that may be the predominant strategy. So what did you feel about CT specifically in your trial?
CT, we were always being quite confident with CT, because in each of our center we work together with radiologists, so we are very in a close contact. Regarding the numbers of our trial, positive CT results led to PCI in 17% of the patients for unprotected left main, and about 75, 78 for non-unprotected left main segment. So I think that this was a good accuracy, which is quite in line with that reported by our literature. And to be honest, we always had a lot of doubts about performance of CT for double stent techniques, but from our data, no limitation emerging in this setting. We bet probably because there were good diameters of the stents implanted both in the LAD and both in the circumflex artery, and this was not mainly a limitation.
That's great, because that's really key for implications of this trial. All right, so what were the key results that you found? And this, just for the viewers, the CT was done at month 6, after randomization, and then after that, based on the CT findings, further evaluation was performed if needed, and then there was the control arm, and the follow-up after that is till 18 months, so basically 12 months after the CT. Is that correct?
Exactly. Yeah, we choose the 6 months cutoff to identify both the early catch-up phenomenon of restenosis and also those quite late restenosis led both to the progression of the disease and also to some problems during index procedure. And this was, quite an index to achieve both the progression of the disease. And we found neutral results in MACE. That is, a CT scan did not reduce the incidence of MACE in overall course, and also in the subgroup analysis, that is, in those performed according to SINTA score, in those performed according to stent strategy, that is provisional versus two stents, and according to clinical presentation, HES versus chronic syndromes. But I think that, of course, CT scan led to an increase of revascularization, and this was quite obvious and is observed in any trial comparing CT versus other strategy. And I think very interesting, led to a reduction of myocardial infarction, which I think was the key message of our study. MI which were had a culprit lesion, located in half of the cases in the left main and the other of the cases in vessels other than the left main. And I think that this is very important because it reflects the aggressive atherosclerotic disease of these patients.
Yeah, that's really fascinating. Like you described, the overall MACE was no different in both the arms. But if you look at specifics of those, there was much more spontaneous MI in the control arm, and then naturally more revascularization in the experimental arm. So that was really, really intriguing. So in terms of the spontaneous MI, what is your hypothesis that they, of the spontaneous MI? Because it seems like, a large proportion was in the left main area, which is basically the target area, but there was also other MIs that occurred in non-left main areas as well. So what is your hypothesis of how there was a reduction in spontaneous MI with CT?
Yeah, this is a good question. I think that this simply reflects also other randomized trials like the complete or the ischemia, because when you do more PCI, you always reduce myocardial spontaneous myocardial infarction. This may not translate in reduction of death, especially yet with a quite short-term follow-up. But I think that when we put a stent following CT strategy, a CT indication, we fix plaques, both those which will provoke a myocardial infarction and those which will not provoke a myocardial infarction. And in some cases, for example, in patients with a lot of cardiovascular risk factors, so who are a very high risk of current MI, this may translate into a clinical benefit. I think that it's like a fixed plaques, and still simply we still don't know which plaques with a good accuracy, which plaques will break to a myocardial infarction and which plaques will simply stay stable for all the life of the patient.
Yeah, and this is also potentially information that you could get before the intervention from CT, especially in the non-left main territory stenosis that you detect. So, that was really a particularly intriguing part of this trial, this kind of balance between more revascularization and then preventing spontaneous MIs. So that was really good. In terms of the follow-up, I understand that we only had follow-up up to 12 months. It would be really interesting to see follow-up for longer period of time. Is there a plan for this trial to follow up?
Yeah, we will do a follow-up at 12 years and 2 years and 5 years. Absolutely, yes. It will be very interesting if this reduction in MI will translate into a reduction of hard endpoints or not. I think that this will be the big next question.
Correct. And I know that as a part of the review process, we asked you to submit all these spontaneous MIs that occurred, and it seems that these are real MIs, and some of them had reduction in LV function, etc. with these MIs. So it is possible that they may have downstream consequences as well. So that will be interesting to see. And then, how it pans out with the additional revascularization. Are there downstream events secondary to that? So it will be really interesting to look at longer term follow-up after this. So that's great. So, a lot of great information, obviously has come out of this study. What are your thoughts on the key clinical implications that viewers should take home from the study, and how do you personally intend to incorporate this in your practice?
This is a good point. I think that's the main key message is that if we have a patient with PCI on the left main, and if this patient has a lot of cardiovascular risk factor, and if his presentation is with an STEMI, we should think to perform a angiographic follow-up for CT in order to try to reduce the risk of subsequent MI. And I think that we are, not only me, of course, but we as a group are starting to plan a CT after 6-8 months for patients who are considered at high risk. And I think this is the most relevant message from our study.
That's wonderful. Yeah, so, great study. We look forward to your presentation at ESC, and congratulations on this study. And thank you for using JACC as your venue for this really awesome study. I'm sure it'll be really interesting for the readers, and a lot of discussion will come out of this. So thanks again, and and then hope to see you around.
Super. Thanks for the interview. It was our pleasure. Thank you.